hear me? No. Yeah, no, it went off again. Good morning. I will use the gavel to call this meeting to order. And we are convening the Board of Health, and our first order of business this morning is the approval of the minutes. Do we have any corrections to the minutes from the last meeting? May I have then a motion to approve? Second? And all in favor?
Aye.
Thank you very much. So then we move on to the main items of business for our meeting today. We are going to hear now a proposal to amend Articles 205, 207 of the Health Code. This is, we have a presentation on it. The board is being asked to approve these for publication. And if you could introduce yourself.
Good morning, my name is Stephen Schwartz. I'm the New York City Registrar of Vital Statistics. We're proposing 3 sets of changes relating to death certificates this morning. The first relates to the confidential medical report of death. As the board may recall, the death certificate is composed of 2 parts, a certificate of death and a confidential medical report of death. We're proposing to expand the access to the confidential medical report of death. I'll go into detail in a moment. We're also looking to propose clarifications as to who can get a certified copy of the death certificate, and finally expanding access to fact of death information. So currently for confidential medical reports of death, actually up until 2010, a confidential medical report of death was almost unattainable. It was confidential, and the rationale, starting in 1949, was that medical providers, medical certifiers, certifying cause of death, that it was felt that the cause of death should be kept confidential from the family to encourage more full and accurate reporting. In those days, diseases like tuberculosis, syphilis, and even cancer were considered socially unacceptable. And the thought was that cause of death would be more accurately reported if it were not available to the family. So in 2010, the board approved the change to allow access going forward, but at the time we thought that, well, all the death certificates written prior to 2010, there was the expectation by physicians that there was confidentiality. But in fact, there's really a need for making this available to certain family members, not the general public, of course. So we're proposing 2 things: to do an expansion for access to the confidential medical report of death, which includes the cause of death, to add siblings, grandparents, and grandchildren, and in addition, make it available for all of our death records from 1949 to present. The second proposal relates to who may obtain a certified copy of a death certificate. So that's what we call the retail side of our business. Family members and customers needing certified copies of death certificates. The current way that we describe who can get a death certificate is really complex, and so it's a problem in 2 ways. It's a problem for our staff. So when, for example, the current health code says that somebody can get a death certificate for personal reasons or as a relative. But what's a relative? So we are proposing to clarify the categories of people who are entitled to get, or are qualified applicants to get a certified copy of a death certificate. So there are 5 categories that we've listed here. Spouse, domestic partner, essentially close relatives, a legal representative or person in control of disposition, a party with a property right, as in a landlord or a creditor. Funeral directors have long been able to get death certificates on behalf of the family. We're proposing to limit that business relationship for only the first 12 months after the registration of the death. And finally, for judicial or other proper purpose, or to prevent misuse of governmental funds.
May I?
Yes.
Do you mind if you want me to wait to ask?
Why don't we,
We'll wait, I'll wait.
if you
I'll just
would
write
hold it.
myself a note.
Thank you.
Go ahead, never mind. I'll write myself a note.
Continue and we'll open
Okay.
discussion and questions.
Yeah.
The third category is actually a new category for fact of death. This may surprise some of the board members that fact of death information is not public. We get questions all the time. Somebody calling to get the vital status of somebody. That is not public information, so we do not release any information except to qualified applicants. So however, fact of death information actually has great value for many purposes. For example, right now the Social Security Administration maintains a file called the Death Master File. However, the so-called Death Master File maintained by Social Security only has about 45% of the deaths in it. So from the standpoint of people who actually have a very legitimate need, like benefit-paying parties, like annuity companies and life insurance companies, actually have a real hard time doing a good job of releasing information to family members, or releasing life insurance benefits, or to terminate annuities. Very legitimate business purposes. So right now, we do not permit New York City data to be used in that way. So we are proposing that benefit-paying parties have access to just fact of death information. Essentially, they would provide first name, last name, date of birth, social security number, and we would be able to provide just a yes or no, or to give them, to let them know that the death had occurred. Second category, very important, for U.S. licensed physicians who have patients lost to follow-up. So right now, some physicians have been using the NCHS, National Center for Health Statistics, National Death Index, but that's not as current as our data is. And there are very legitimate needs for physicians to be able to know the vital status of their patients. So this would be a second category, new, that we're proposing to provide fact of death to licensed physicians. And the third category is to provide fact of death information to U.S. licensed attorneys for estate settlement purposes. So not just for any reason, and not just any attorney, but an attorney needing fact of death information specifically for estate settlement purposes. So we're proposing those 3 broad uses in this proposal. And I'd be happy to answer any questions.
Good. So, tell me if the spouse, domestic, if all the people in one are not available or dead or not around or whatever, what's the mechanism by which some other next of kin, or is it intended not to do that? Do you know what I'm saying?
So this is in the category of a family member needing to get a certified copy of the death certificate.
So,
So they would have to demonstrate to us some proper need.
Fine. Okay, then, the party with a property right. So, that made me, so people, who have claims against the estate of the deceased or landlords, what's the, sort of, how do you define what would be, who people with a property right? It's only landlords? I'm not being very articulate here.
No, I think the question is clear. Is
It
it,
makes me a little nervous.
Somebody would have to demonstrate, excuse me, we need to see a document. So it's not enough that somebody simply represents that they have a property right, but they would show us a lease, a creditor would show something. So a document, an insurance company that needs it would show a life insurance policy to us.
So, I mean, you're so terrific and your office is so terrific. So you're going to issue clear guidelines to your staff about how to sort of define that. That was not the crispest explanation I've ever heard. Yes?
It's actually, right now, our existing rules, the way it's written in health code today, it's actually very hard to decipher. It's hard for the public to decipher, and it's hard for our staff to decipher.
Yes.
So this way, it's actually much more explicit, it's more specific, so that it will be more useful and it will be easier for us to communicate to the public and to our staff how best to identify who is a qualified applicant.
So I feel better about not being so clear myself here. This is good. Okay, thanks.
additional questions?
Dr. Schwartz, thank you for this presentation. I had a question regarding the confidential medical report of death. As we know, when a patient, a person is alive, we privilege their confidentiality of medical information. And if I'm understanding this correctly, after a person's passing, the cause of death and the death certificate would be available to certain individuals upon request. How do you take into account an individual who, while living, would not have wanted that information released to other people? Could you consider that in this provision you're proposing?
Yes. Actually, today we get very few requests for cause of death on the death certificate. And generally, and actually what we've done up until now is we referred family members back to the medical providers because that's really the best source of information. And the physicians know that death certificates are often not the best source for the accurate cause of death. So we encourage families to go back and ask their medical provider. In terms of a decedent or predecedent, not wanting the cause of death released, that might be something that would be communicated to the family members themselves. As I say, we get very few requests for it right now, and we do feel it is important, and I think it's important too to actually encourage full and accurate reporting. That one of the things that we find is that we get requests for corrections and amendments on vital records. And the requests we get are the result of a family member seeing the information on the certificate. So when the family doesn't get the confidential medical report, they don't know what was actually reported. So if they have an opportunity to see it, we actually feel that the reporting quality will actually improve. And again, it's limited to only close family members, not just any family member. So the limitation is spouse, domestic partner, parent, child, person in control of disposition, sibling, grandparent, and grandchild.
Have you considered what the potential risks of this are, this provision?
We felt they were minimal.
Thank you.
Dr. Brewer, Dr. Flitzman, and did you have your hand up? Oh, I apologize, Dr. Coleman went first. Had his hand up first.
Okay. Thank you, Commissioner. Thank you for the presentation. I had three very quick questions. One, just to clarify what you just said, which is, my understanding is there is no provision for the department to mark the cause of death as confidential at the request of the predeceased. Is that correct?
That's correct. That's correct.
Which I think is fine, but just wanted to be clear. A very quick question for confidential medical reports of death. You said up from 1949 forward. I presume you don't have that before 1949?
Correct. Prior to 1949, the records were public.
And then my last question is about the fact of death, which actually is interesting. You talked about three parties that could call and request that, sort of insurance companies, businesses with a legitimate interest, licensed physicians, and licensed attorneys managing the estate. This is an issue that's come from my own institution, which is related to medical records in the hospital. And periodically, and actually fairly regularly, a patient will have died, but it doesn't get, we've been struggling with how do we verify that for the medical record, because it triggers really annoying and sometimes insulting phone calls, follow-ups to families of patients who died, have come get your flu shot, or things that they then get understandably distressed about. And so we were looking for a mechanism that we could, without too much burden, sort of verify this when we heard from that someone had died, that we could then mark them as deceased in the record and stop all these automated, intrusive calls, emails, letters, etc. And so I wondered if amongst these parties, hospitals might be included as representing physicians, or if there's a mechanism to allow medical, health networks, etc., people who manage the medical record to be able to verify just the fact of death, so then they can make those changes.
Exactly right. It is within your power to approve this.
Could we, would people think that would be a legitimate
Yes.
change to this? I think it would be helpful. We get, again, I'm on the medical records committee at my hospital. It's hard when you hear people who get very frustrated, died 6 months ago and you're still sending me this stuff. It seems very insensitive.
Yeah, we're going to be having a public comment period, and there may be other people as well who have legitimate need to correct that. But I think it's certainly something we've heard an option, and when we come back with the final language, we can address that.
I just didn't know if there was sort of legal barriers to that sort of thing, but just the fact of it seems helpful.
Exactly. There is a legal barrier today. We cannot do it
So we
today.
can change it.
We are proposing to change it.
Thank you.
And Dr. Brewer.
Two quick questions. What is the reason for giving the parties with the property right the confidential medical document as opposed to the fact of death? What's their need to know that information?
Perhaps I wasn't clear in that. A party with a property right would be able to get the certified copy of the death certificate, not the confidential medical.
Oh, okay.
Yeah.
And the second thing is, how are you, what's the process for identifying the person that you're giving this documentation to and the kinship to the person that's deceased?
Well, the process that we have today is that there's a representation from a family member to our Vital Records office. So right now, it's actually been, as I said, the current health code reads that it could be simply, it's said relative, which is way too hard for us to interpret, and it's also difficult for a family member to understand, am I eligible or not? So by being more explicit about the family member relationships, we felt that would make it easier for both our staff and for our clients.
I think the question was, how would somebody prove their relationship to the decedent?
Dare I say that we trust them? We essentially do. For when they make a representation and they're signing that they are essentially an authorized party, so we accept that. We wouldn't do that for a birth certificate, But death certificates do not have the same protections, nor need the same protections as a birth certificate.
And did I hear you correctly, that birth certificates, death certificates before 1949 are all public information?
Correct.
And Dr. Klitzman?
Thank you.
And then Dr. Kara. Oh.
Thank you, Dr. Schwartz, and thanks to your Bureau for your work on this. I just have a few clarifying questions. The first question is, how are non-biological and adoptive relatives like step-parents and step-grandchildren treated under this provision?
In terms of getting a certified copy of the death certificate?
Correct, yes.
They would be eligible.
Okay, thank you. And a couple of questions about the fact of death process. You said that the requester would need to submit the social security number. Is that tracked systematically by the department?
Your question tracked what?
Well, is there a way, do we have a record of the person's social security number linked to their death certificate?
Yes, it is collected by the funeral director. So the funeral director collects that information, and actually we, through a contract with we in every vital records office in the United States, sends that information electronically to Social Security Administration to help them terminate benefits quickly.
Thank you, yes, that's what I was asking, thanks for the clarification. And then my last question is, can you explain whether there's a mechanism if a New York City resident dies out of state to retrieve the information about the death and verify the death and have a record of the death?
Yes, there is. As the board knows, we are one of 57 vital registration jurisdictions in the United States. There is an interjurisdictional exchange program that records are exchanged both for place of residence and place of birth.
Thank you.
Does it change the new proposal, if a close relative want to know, change the information on a given illness? I remember one of my patients who used to be a heroin addict and quit 30 years ago and died from complication of chronic hepatitis, and the family want to put first the chronic hepatitis, not the heroin addiction. Does it change?
So the question is, can a cause of death be changed that's been reported on a death certificate? And it can be, but not by the department. It would have to be changed by a physician who would be willing to, from that same institution or practice, so that they would have to make an amendment, and then we would update that record upon signature of a licensed physician.
Are there any further questions from the board? In that case, I'd like to thank Dr. Schwartz for a clear presentation and remind the board that this is a request for approval for publication, so that the proposal will be posted for public comment, and ask if I can have a motion to approve.
So moved.
Second. All in favor?
Aye.
So the motion passes. Thank you.
Thank you.
Will you be presenting on the next proposal? All right, this will be Dr. N.Y. So the next proposed legislation also to amend Article 207, Section 207.05 of our health code will modify the requirement for converted surgery in transgender birth certificate applicants. We have a presentation. Can you introduce yourself?
Great. Hi, my name is Gretchen Van Wy, and I'm the Assistant Commissioner for the Bureau of Vital Statistics at the Health Department. I'm going to propose an amendment to Article 20705 of the Health Code pertaining to transgender birth certificates for people born in New York City. The Health Department is responsible for the registration of all births in New York City and is one of, as you know, one of 57 independent vital records jurisdictions in the United States. Currently, to change sex on the birth certificate, we require a name change, which is processed by the court system and provided to us as a court order, and proof of convertive surgery. This must include a surgical report and documentation of a post-operative exam by a physician. Upon approval of a gender change on a birth certificate, our procedure is to allow the issuance of a new birth certificate that reflects the amended gender marker and the new name. In addition, the original record and the materials associated with the application are put under seal. The original record is not made available except by order of the court. Today, we are proposing to remove both the surgery requirement and the requirement for a name change in order to process a gender change application. Other jurisdictions and agencies have made changes to their gender amendment regulations, and all but 3 states in our country amend birth certificates for transgender people. The U.S. model law for the regulation of birth certificates, promulgated by the National Association for Public Health Statistics and Information Systems, which has been published regularly in the United States since 1907, removed the surgery requirement in its 2011 version. Instead, the model law requires a court order. Recently, 5 other vital records jurisdictions removed their surgery requirement and instead require either a court order or a letter from a licensed healthcare provider, typically a physician. Federally, in 2010, the U.S. State Department removed its surgery requirement as well, and now instead requires an affirmation from a licensed physician practicing either internal or family medicine, endocrinology, gynecology, urology, surgery, psychiatry, or pediatrics. Today we are proposing that a gender change on a birth certificate in New York City be processed upon receipt of an affirmation or affidavit written by a licensed health or mental health provider as specified here. Specifically, we propose that this document may be signed by a licensed physician, doctoral level psychologist, clinical social worker, physician assistant, nurse practitioner, marriage and family therapist, mental health counselor, or midwife. That affirmation or affidavit must include the professional's credentials and a statement that, in keeping with contemporary expert standards regarding gender identity, the applicant's requested correction of sex designation of male or female accurately reflects the applicant's gender identity. The rationale for these changes is multifold. First, surgery is not the only way an individual can indicate a commitment to changing sex. And with regard to name change, many people want to use their same name before and after they transition. Second, the surgery requirement may present a burden for transgender people who wish to update their birth certificates to accurately reflect their gender. And third, it is important for individuals to have birth records that reflect their gender. This is important for many reasons, including obtaining access to health care and employment. There is another consideration that is always on the forefront of our thinking in vital records, and that is maintaining the integrity of our documents. Birth certificates are scientific, legal, and foundational documents upon which all other official identity documents are based, including passports, driver's licenses, and social security cards. Moreover, they are proof of U.S. citizenship and may be amended only upon presentation and acceptance of proper evidence. This evidence is critical to maintaining the integrity of the National Vital Event Registration System, which is an interconnected web of mutual reliance. As an independent vital records jurisdiction, New York City works in close partnership with the federal government, New York State, and the 55 other vital event registration systems in the United States to ensure the accurate representation of facts of birth. Together, across the United States, we register nearly 4 million births each year, and we maintain the birth records for all of these individuals throughout their lives and after their deaths. Clearly, without birth record integrity, passports, driver's licenses, and other core identity documents would be questionable, not only for us, but for those other jurisdictions and organizations that rely on us as well. As proposed, we are confident that these possible changes to Article 207 will make it easier for transgender individuals to obtain birth records that accurately reflect their gender while maintaining the integrity of New York City birth certificates. The list of providers is diverse, but consistent in its requirement for licensure. These providers have credentials that are able to be evaluated and validated, and they are also subject to professional sanctions, penalties, and prosecution if they provide false information. In sum, we are confident that by removing the surgery requirement, as well as the requirement for a name change, we will increase access to and considerably ease the administrative burden of gender transition, while also maintaining the integrity of these documents. Finally, the proposed amendment to Article 207 maintains the current practice of sealing gender amended records. Specifically, the original birth certificate and the materials associated with the application to change it are put under seal and not made available except by order of the court. When a new birth certificate for the registrant is requested, it is the new amended certificate that is issued. I wanted also to share highlights of the outreach and implementation plans that we are drafting to make people aware of this change that occurs. First, as people born in New York City live across the United States, a national outreach plan will be developed with input from key stakeholders. Resources in other cities and states will be identified, and information on how to apply will be shared widely. Second, with regard to implementation, the department will continue to ensure that a point person with experience working with the transgender community can facilitate the transgender birth certificate process. Thank you. I'm happy to answer any questions that you might have.
Thank you, Dr. Wahai. We are now open for questions. Dr. Foreman.
Thank you so much. It was a very clear presentation. I had two questions. One, I think, larger. The first is, after reading the materials we got and listening to the presentation, it sounds like the number of professionals who can present either an affirmation or an affidavit saying that an individual has changed their gender is broader than any other jurisdiction I read about. It includes many others. And although they are all licensed, I don't know all the details, but licensing as a physician is a little different from licensing as a counselor. And given how important the integrity of the record is, I wondered what the justification was for being that broad, and whether there are any potential downsides to being that broad.
Thank you for that question. So when we were thinking of the best way in which to develop proposed regulation, we reviewed the existing policies of Washington, D.C., of the State Department, of other jurisdictions and places. And while our overarching goal is to really maintain the integrity of our certificates, we also felt that by having a list of people licensed to conduct assessments and to make diagnoses was critical. So we reviewed the scope of practice of professionals that are licensed, and we included ones in whose scope of practice these types of assessments can be made. And so that's one thing that we did. We also know that we're able to verify licensure for these individuals, so that's a critical piece as well. And did you have another question?
Just a quick one. For the physicians, MD and DO, you talk about an affirmation, but for all the other providers, you said affidavit. Is that different?
Yeah, it's under New York law. You may not know this, as physicians under New York law, you're able to file an affirmation where lawyers too, but other people have to do affidavits.
Thank you. Are there further questions to the board, Dr. Kavanaugh?
What about, I remember one of my patients in the 90s that since the age of 13, who was already on Social Security retirement, was living as a female, but he had male genitals. And my question when I was seeing him as a family physician was, if this patient died, what do I write in the gender? Because he never changed his birth certificate. What a person today already living as a female or vice versa, never changed the birth certificate, has to do if never got the surgery.
That's an interesting question, and it's one that I think is important to the filing of death certificates. However, in general, when people are not reviewing the birth certificate when completing a death certificate, and for additional information, that I can turn to my colleague Steve Schwartz.
We would ask this is a decision that's actually, the funeral director completes a portion of the death certificate, and the physician completes a portion of the death certificate. So we would expect that the providers would be sensitive to that, and if not actually asking the patient at the time prior to death, that they might ask the family, and that we would respect that.
Thank you both. Epidemiologic question. Do you have any sense from either the affected community or perhaps other jurisdictions how these proposed changes might affect the number of requests and reporting?
That's a great question. We have spoken to other jurisdictions that have recently made these types of changes, and they have seen a slight increase in the number of applications. We typically have about 20 applications a year, which is similar to what New York State experienced after their change. They've probably gotten, they've maybe doubled their applications, but it's not been more than 50. Similar trend in Washington, D.C.
Thank you.
I'm sorry.
Yes, right.
I'm still, I don't know why I'm sort of a little bit uncomfortable with the list of people who can certify this or attest to this. Yeah, they are all health-related personnel, it's true, but some more so than others. And I was hoping that you would just spend a little bit more time, I know you asked this question, on your sort of underlying sort of philosophy, if you will, of this.
Absolutely. So our underlying rationale is to maximize access to this while also maintaining the integrity of our documents. And it is a fine line, and it is important to consider the ramifications of overextending that access. However, what we are proposing today is something that we are today comfortable with, and
Fine.
Could I ask if you could comment, the New York State, as I recall, has included physician's assistants, nurse practitioners, as well as medical doctors, and can you just comment on those categories and the experience of the state? It is
absolutely.
expanded beyond just medical practitioners.
Absolutely. So what we've seen from the New York State experience, which they've had, as I've said, slightly under 50 applications, the vast majority of the documentation that they have received has actually been signed by an MD or a DO. So what our expectation is that in general, people will reach out to their family doctor or another doctor with whom they have a relationship, but in some cases, this will be helpful to them.
Thank you. Was there another question on this side? On this side? In that case, I thank you for a very clear presentation, and we now need a proposal to approve for publication this resolution.
So moved.
And I need a second, and all in favor?
Aye.
Aye.
So the motion passes, and we will have approved for publication the proposed resolution to amend Article 207 to 7.05. Now, let's just do the form, and then I think we're going to change the agenda around a little bit and go straight to the presentation on Ebola, which I know is on many people's minds. Can we hear about the change to the transgender birth certificate VR-13?
Absolutely. Thank you. In addition to proposing changes to the requirements for the transgender application processing, Today, we are also proposing to revise the form used for transgender birth certificates, which was last revised in June 2009. Currently, our certificate reads, "This certificate is filed pursuant to subsection 5 of subsection A of section 20705 of the Health Code of the City of New York, which cites the specific section of the Health Code that applies to transgender birth certificates." We propose that the text instead be more general and refer to the broader section that refers to transgender adoption and parentage amendments. Specifically, the language would read, "This certificate is filed pursuant to section 20705 of the Health Code of the City of New York." We also propose the removal of extraneous text on the left side of the form, which is no longer necessary as it is recorded electronically. So this is a picture of the certificate as it currently appears. The areas that we're proposing for change are highlighted in yellow. On the left is the extraneous text, in the center is the reference to the health code. And this is the proposed certificate, clean on the left, with more general text on the certificate itself. Thank you.
Thank you. Any discussion on these changes? May I have a motion to approve? Second, and all in favor?
Aye.
Motion passes. Thank you all.
Thank you.
So we will now proceed to a presentation for the board on the steps and precautions that New York City is taking to prepare for an Ebola case. And Dr. Farmer, please.
My name is Dr. Jay Varma. I'm the Deputy Commissioner for Infectious Disease Control at the New York City Department of Health and Mental Hygiene. We'll be having two of our staff give a presentation to you about the Ebola situation in New York City. In New York City. I just wanted to emphasize before we begin that there is a tremendous amount of attention paid to this issue, primarily because of the humanitarian crisis in Africa. And we here at the Health Department are obviously very concerned about that situation. But of course, our first priority is to protect the health and safety of New Yorkers. And so for months now, we have been actively engaged in a broad number of activities, both internal to the department as well as externally, to ensure that we are prepared to identify cases early, isolate them, track their contacts, and evaluate them effectively. So today we'll hear a detailed presentation, and we look forward to comments from the board about ways in which we might be able to strengthen our preparedness, particularly as it relates to our engagement with the healthcare sector and the general community, both to reassure them as well as to make sure that we are fully prepared for any event that may occur. So we'll have two of our staff give a detailed presentation right now.
Thank you, Dr. Varma, and welcome, staff. If you could introduce yourself.
Good morning, I'm Dr. Isaac Benoist. I work under Dr. Varma. This is a Division of Disease Control.
And good morning, my name is Celia Quinn. My name is Celia Quinn, and I am the Medical Director for the Bureau of Healthcare System Readiness, as in the Office of Emergency Preparedness and Response.
Good morning, all. Thank you for the opportunity to share a few words with you and talk about what's been going on with preparedness for Ebola here in New York City. So just a brief outline of what we're going to talk about this morning. I'm going to say a few words about what's going on in West Africa. I'm sure everyone has been following the news very closely, and I'll just say a few words. Also talk a little bit about Ebola. It's important to recognize a few things about how it's transmitted and what the disease looks like when it first appears. After that, Dr. Quinn will spend most of the time talking about what we've done for preparedness here at the Health Department and what we've helped to establish across the city in hospitals and other agencies. And then I'll talk a little bit at the end about the surveillance that we've done for possible Ebola cases here in New York City and how that experience helps us understand our readiness. So, as Dr. Varma mentioned, this is really something that's happening in West Africa. All of the action is in 3 countries, Sierra Leone, Guinea, and Liberia, where an initial case of Ebola that is believed to have been in Guinea at the end of December of last year turned into a larger outbreak of Ebola virus disease in Guinea and then spread over some porous borders to Sierra Leone and Liberia. At this time, the official numbers are over 7,000 cases and over 3,300 deaths. But there is some thought that with the inadequacy of tracking cases and their contacts and other people who develop symptoms, those numbers may be off by a factor of 2 to 3 times. So it's a huge number of people affected in those countries. A few words about Ebola virus disease. So it is transmitted person to person, but it can't be transmitted through the air. It requires close contact with infected bodily fluids, predominantly blood, vomit, and diarrhea, stool. It can be transmitted through sweat, but that's felt to be less significant. It's very important to understand that it's not transmitted through the air, which means that just being in the same room as someone who has Ebola is not a risk factor for getting the disease. There are concerns, there have been a lot of concerns voiced in the news media about concerns of whether this could be transmitted through the air. This is something that we have been studying for decades. There have been upwards of 20 other outbreaks over the last 40 years. We understand the transmission dynamics very well. So it's not spread by the air, and it's also important to recognize that it's not contagious before symptoms appear. So this is a sharp contrast to a disease such as measles, where patients can infect others as early as 4 days before they have the onset of symptoms. With Ebola, that's not the case. So someone who is not clinically ill, someone who doesn't appear sick, can't make other people ill. What makes Ebola very difficult to recognize is that it shows up with symptoms that are very similar to a number of other diseases found in West Africa and other tropical regions. It typically presents with a high fever, which is often accompanied by headache, body aches, weakness, vomiting, diarrhea. These are symptoms that also show up in other permutations with influenza, with malaria, with typhoid, cholera, other diseases that are found in those regions. Symptoms typically present between 2 and 21 days, but most often within 8 to 10 days of the exposure. We don't have any targeted medicines that treat Ebola, but hospitalization and a high level of critical care medicine are very important. And we do think that those produce much better results than what a number of patients are unfortunately able to access in hospitals in West Africa right now, where the fatality rate is around 70%. So I'm sure most of you saw the news last week that there is now one recognized case of Ebola that was diagnosed in the United States. This is a man who flew from Liberia to Dallas, Texas, presented to a hospital there. Apparently the initial time that he presented to the hospital, the diagnosis wasn't recognized, and when he came back a few days later, they recognized it for what it was, and there's now a large effort going on in Dallas to make sure that there are as few secondary cases as possible. But this is really just the tip of the iceberg. This is what we heard last week. It certainly kept us a little more on our toes, but as Dr. Varma mentioned, this is something we've been preparing for here in New York City for months. So in New York City, we're always on guard against diseases that are more prevalent elsewhere, outbreaks in other corners of the planet. We have a lot of travelers, we have a huge amount of commerce here in New York City, and in a way that does make us a target. There were 2 things that happened with this Ebola outbreak in recent weeks and months that really put us even more on guard. So that picture on the top left is a picture of Lagos, Nigeria. In late July, a man with Ebola virus disease flew from Liberia to Nigeria, causing several waves of cases of Ebola in that country. That now appears to be under control, but it was definitely a scary moment and a very clear reminder that transmission through air travel is a reality. The other picture in the bottom right shows the first U.S. healthcare worker who was infected with Ebola in West Africa. That's a picture of him showing up at Emory Hospital, where he was medically evacuated to from West Africa for treatment. We believe that most hospitals are prepared to take care of Ebola patients without any secondary infections of healthcare workers or other patients, but certainly a lot of the publicity and a lot of the reporting around the care of that patient raised a lot of questions about whether we were doing enough and whether there were other things that we could do to strengthen our systems. So at this point, I'm going to turn it over to Dr. Quinn to talk a little bit about what we've been doing here at the health department and what capacity we've been helping to build in New York City.
Great, thank you so much for your overview. So I'm going to be talking about preparedness for possibly managing an Ebola case in New York City. And I'm going to describe each of these items on the following slides. I'll talk about our development of guidance for providers and facilities, protocols that we are using for conducting surveillance, our ability to do laboratory testing for Ebola virus. I'll talk a little bit more detail about hospital preparedness. We'll also address interagency coordination and community engagement, another important piece. So as Isaac mentioned earlier this summer, one of our first activities was to provide information, guidance, and tools to healthcare providers and facilities. We did that by sending out initially 2 electronic health alerts to our Health Alert Network. That was the first on August 11th and then a second one on September 3rd. These health alerts provided information about the Ebola outbreak in West Africa, what to look for in patients, and what infection control precautions are recommended to protect healthcare workers and other patients in healthcare facilities. We also provided an algorithm for healthcare assistants to use to ensure the identification and reporting of suspected cases, and I'll show that on a following slide. We also did develop some specific guidance for certain settings, emergency departments and outpatient settings, because those are really the first line of defense against these type of infectious diseases emerging in the community. So it's really important that our providers in those settings ask every patient with fever about their travel history in recent weeks, and if those patients were in an Ebola-affected area, they need to be isolated in a private room with proper infection control precautions until further details can be obtained. So that's the message that we've been putting out to New York City health facilities since the very beginning of August. The pictures on this slide, the posters on the right, were initially developed during concern for other diseases, including measles, influenza, SARS, and MERS. So we also made sure this summer that those posters were available in the most common languages spoken in the affected areas, as well as the most common languages spoken in New York City, and we've made those available to all of our healthcare facilities. So in addition to the electronic communications that I just described, we also hosted 3 conference calls so far with all of the New York City hospitals, and other healthcare agencies were invited to those as well. Our health department staff have given presentations around the city to a lot of our key partner organizations. So Greater New York Hospital Association, the Infectious Disease Society of New York, and the Association for Professionals in Infection Control and Epidemiology, among others. So I mentioned that I wanted to talk a little bit about the evaluation algorithm, and that's pictured here on the right. This document is an important part of the guidance that we've provided to providers and facilities. And it forms the basis of our forms the basis of our enhanced surveillance for cases of Ebola virus disease in our city. So we've asked physicians to report what we're calling persons of interest, that's people who meet certain criteria, in order to identify those who might be at risk of having Ebola virus that we may want to investigate further. So this document basically emphasizes, again, the importance of obtaining a travel history on all patients who report, on all febrile patients. And the patients who report having been in an Ebola-affected area within 21 days before they first became ill are the ones that constitute a person of illness that should be reported to us for further evaluation. It's important to recognize that most patients with fever and travel history to West Africa are not likely to have Ebola. As Isaac mentioned, there are many other diseases they could have, such as malaria, typhoid, fever, influenza, or others. So this algorithm also provides specific questions to help determine the patient's risk for Ebola virus disease based on their exposure to Ebola while they were in the affected area. And you'll hear more from Dr. Benowitz at the end of the presentation about our early results from this enhanced surveillance. So at the same time that we were developing our guidance for use in the healthcare system, we revised, updated, and in some cases developed new protocols to help our physicians respond to the calls from physicians reporting persons of interest. So some examples of these include protocol for our on-call 24-hour DOH physicians, specific outline for managing a person of interest, additional protocols for contact tracing in the event that we were to find a person who had confirmed Ebola virus disease. And we also revisited our protocols for managing an ill passenger who arrives at JFK Airport. We've also worked with our legal department to create draft legal orders that could be used in the event that a patient with suspected or confirmed Ebola virus disease or in a person with a known exposure to Ebola who could pose an infectious risk to others if symptoms develop, that they could be detained if they were not willing to comply voluntarily with quarantine or isolation in a safe location. So I want to now talk about laboratory testing. So the Ebola-specific testing can't be done in a regular clinical laboratory because the PCR test that's used is normally only available at CDC and in certain research laboratories. However, this testing is now available at New York City's Public Health Laboratory. Consultation with CDC is done before any testing would be performed, and the test results would be available 6 to 8 hours after the specimen arrives in our lab. But confirmatory testing would also have to be done at CDC. So you may recall that in early August, there was a patient in New York City, in a New York City hospital who was tested for Ebola. And that test actually occurred before our public health lab had access to the test. So that test was done at CDC, and you'll recall it was negative. So far, we haven't yet needed to run any Ebola-specific testing for any patient in New York City, but the test is ready to go. So now I want to talk about hospitals and the healthcare system preparedness in New York City, and how we've been working to enhance preparedness for the possibility of managing an Ebola case. So the overarching goals for healthcare system preparedness in this area are threefold. The first is to prepare to detect a patient with Ebola. That is, develop the capability to quickly recognize a patient who's at risk for Ebola, to notify appropriate facility and staff and the local health department, us, and to perform the necessary testing to confirm or rule out Ebola virus infection. The second is to prepare to protect healthcare workers so that they can safely care for the patient. That is, they need to be ready to quickly isolate a symptomatic patient who have traveled to the affected area. We need to provide the healthcare workers with appropriate personal protective equipment and training in infection control procedures. And we also need to develop guidelines and procedures for the safe handling of clinical lab specimens, medical waste, linens, and other equipment, among others. And finally, another goal is to prepare to respond in a coordinated fashion to an Ebola case. So that means to review, implement, and exercise our policies and procedures with the staff, and review and exercise protocols for sharing relevant information with key stakeholders. So although the items that I just mentioned on that long list of preparedness topics, they don't fall too far outside the normal operating procedures of U.S. hospitals. But our efforts to be prepared for an Ebola case have encountered certain challenges that I want to outline briefly. So first, the U.S. Department of Transportation regulations categorize Ebola-contaminated waste generated in the clinical care of a patient with Ebola as a Category A hazardous material. And that prevents the disposal of waste using a hospital's normal regulated medical waste contractor. Instead, the waste would have to be pre-treated in an autoclave, which is a steam sterilizer. And I have to say that this issue has been one of the most challenging for the hospitals that we work with to plan for, because the large amount of waste that would be expected to be generated by even one sick Ebola patient would be very difficult to handle in that manner. And hospitals don't routinely process large amounts of waste in that way. So secondly, some facilities have encountered high levels of concern among their staff, including their clinical and laboratory staff, perhaps prompted by some of the images that they've seen, such as the one on the slide here. But this human element of how to respond to an Ebola case is a really important factor to consider and include in our facility level planning in the city. And finally, although it's not strictly consistent with CDC guidelines for the handling of clinical laboratory specimens from patients who may have Ebola virus, many of our facilities have decided that they prefer to pursue point-of-care testing for clinical lab tests needed for an Ebola patient. So the point-of-care testing would be done in the patient care area or nearby for a confirmed or a high-risk patient. And that capacity is not available at all facilities. It's expensive and time-consuming to develop and requires additional staff and sometimes new procedures. So that's been a real challenge. So although it is true that any U.S. hospital with meticulous infection control practices can safely care for a patient with Ebola virus disease, because of the challenges I just mentioned, we opted early on to work with Bellevue Hospital to develop the capacity to care for patients who have either suspect Ebola virus disease and a known exposure, a known high-risk exposure to Ebola, or a confirmed Ebola patient in their secure isolation ward. So this quarantine and isolation unit at the hospital has been supported through an existing contract with DOHMH and Bellevue. And the unit has been used by our health department since the 1990s for the isolation of certain tuberculosis patients. The unit would be used, in this scenario, the unit would be used for a clinically stable patient who's identified at JFK Airport, or it could also be used for a patient who would be transferred from another New York City hospital at that hospital's request and with the approval of a DOHMH physician. So the isolation unit there features 2 beds that are on a secure unit. It's separated from other patient care areas, and it does now have critical care capability for very ill patients. They've also developed a mini lab that's on the same unit, although not inside the patient room, and they have also been working on very detailed protocols for putting on and taking off personal protective equipment in ways that most reduce the risk of healthcare workers' exposure to Ebola on the unit. But our activities related to Ebola preparedness don't stop with our hospitals. So some of our other work has included that we have updated our protocols with the CDC quarantine station at JFK International Airport and with our partners at Port Authority. We have also been coordinating with Sydney EMS to develop plans for safe transport of patients who have suspected EBD or who may have EBD. And we've also held some discussion with NYPD about plans for safely managing a patient with Ebola who's not compliant with isolation orders. We've also spoken with the Office of the Chief Medical Examiner to address concerns about the handling of decedents with confirmed or possible Ebola virus. Finally, last month we did some planning for any possible cases that might be related to United Nations General Assembly travel. As you might imagine, those plans involve multiple city, state, federal, and international agencies. Finally, we've also recently held an interagency discussion around, again, the handling of medical waste among city and state agencies that will be involved in the policy around that. So this is just a screenshot from the DOHMH website, and it shows our links to some of the communications tools that have been developed for outreach to communities. So in addition to documents that we've developed, such as one called Am I at Risk, which is targeted to recently returned travelers, we have also coordinated with other city agencies to provide information directly to the leaders of immigrant communities from the affected areas. And we've also contacted nonprofit groups that are providing staff to the medical response in West Africa to make sure that they're aware of guidance about returning healthcare workers and to find out how we can support their work. So now I'm going to turn it back over to Dr. Benowitz to go over the results of our surveillance that we've been doing so far over the past few months.
Thanks. So the brief story is that there's still no Ebola here, and that's the really important thing for public safety. But we've been collecting information on the enhanced surveillance that we've been conducting for the last 2 to 3 months, and it tells us some important information, not just about who's coming into the city, but also about how prepared our systems are. So the numbers, these numbers are current as of about a day ago. We've received 88 phone calls, mostly from physicians, about patients, mostly in emergency departments, where there was a concern for Ebola. And so to reiterate, these are calls that should have been generated by our reporting algorithm, the one that I talked about a few minutes ago, that asked doctors to call us about anyone who had been in the 3 affected countries within 21 days prior to the onset of their symptoms, who had a fever and other symptoms that are non-specific but could match Ebola. So of those 88 calls, actually only 11 of them were actually people that met our travel and symptom criteria. I'll talk about those more in a moment. 49 other patients were people who had most of them had traveled, many of them to other countries in Africa, and physicians just wanted to check. And that's okay with us. We're very happy to share information. Those are good opportunities to reinforce messages. It's not a lot of work on our part to have those conversations, so we were happy to take those calls. 28 other people we heard about, 28 other patients, had been to affected areas but didn't have symptoms that matched Ebola, either because they already had a diagnosis of malaria or something else and were starting to improve, or they didn't have a fever, with fever being something that's very characteristic of Ebola, or they had a clinical picture that just didn't match the severity of illness that we typically see with Ebola. So those are the numbers, but those numbers I think tell us a lot more. They tell us not just that there were no Ebola patients, they tell us that doctors are calling us. They tell us that doctors are aware of our guidance. And they also give us some information. They give us opportunities to talk to these clinicians and hear how the other information that we're sending out is actually working in practice. So let me talk a little bit more about those 11 persons of interest, as we call them. So I already mentioned none of them had Ebola. All of them recovered. Malaria was diagnosed in 8 of them. 1 person had typhoid. The other 2 recovered within 1 to 2 days without any clear clinical diagnosis. So a number of respiratory viruses, GI and gastrointestinal viruses that can produce similar symptoms that quickly go away without any specific treatment. But these also gave us opportunities to talk to these doctors about what was happening, find out whether these patients that they were concerned about were actually in proper isolation precautions to limit secondary spread of infection if it was Ebola. And to find out how systems were working more generally. So we found out that clinicians were aware of our guidance. They were all calling not because they heard about something in the news or something from CDC, but because they had this algorithm that we sent out and posted on their walls around emergency departments. We heard that patients were getting asked about their travel history, that they were seeing those signs up front in emergency departments, and that they were getting isolated quickly. If a patient were to sit in an emergency department waiting room for 3 hours, vomiting, potentially infecting other people around them, that would be considered certainly less than ideal. And so these were good opportunities for us to see that hospitals are actually responding very well. They were asking these questions up front, and they were isolating patients appropriately. And so, in summary, the surveillance that we've been conducting and the conversations that we've been having with hospitals give us a good sense that our healthcare system is very well prepared at this point to detect cases, to protect healthcare workers and other patients and the public, and to respond to a patient with Ebola. This relies on collaboration within the healthcare system. This is not just the systems that we're building here, it's very much the capacity that we're helping to build at hospitals. We're really happy to see what's happening across the city and proud of the work that's being done in those hospitals. As I just mentioned, we feel that our protocols are working. All these calls have also given us plenty of opportunities to refine and exercise the guidance that we're building for our own on-call doctors and our surveillance unit. And then most importantly for public safety and public health, there are still no cases of Ebola here. So I'll end there. We'd be happy to take any questions.
Thank you very much. And I'll start from my left.
I want to thank you for this presentation. This is an issue that's been on a lot of people's minds, and you've articulated it in a very clear fashion. And I want to applaud you for a preparedness plan that seems very broad-ranging and very reassuring. Thank you for that. I have a few questions for you. You mentioned the preparedness plans you had at JFK in terms of educating the staff there. Can you talk a little bit about what that educational effort is like and what their preparedness is like, and talk about other potential points of entry that may also be vulnerabilities for our city?
I can address that a little bit. Yeah, so we have had a protocol in place with the CDC quarantine station at JFK for a long time. CDC has jurisdiction over international ports of entry, whether it's JFK, another airport, or international ports. And that's actually overseen by the quarantine station that's located at JFK and staffed by CDC staff. So those quarantine station staff are actually responsible for doing the outreach and education to other Port Authority staff to help them identify patients who may be ill, whether on a plane or after they get off the plane and before they reach Customs and Border Patrol, or they also do a lot of work with Customs and Border Patrol so that they can also help to identify ill travelers from the affected areas.
Okay, thank you. A question about the 11 persons of interest that were identified with symptoms that ended up not being Ebola. Did those persons, were they recently returned from Africa, and if so, did they not have symptoms when they entered through our ports of entry? Do we miss those people at JFK and other points of entry?
It's a great question. So Ebola symptoms can develop anytime within 21 days of exposure, typically within 8 to 10 days. We did ask about whether any of those people had symptoms during air travel and on arrival. None of them had the symptoms during travel that they presented with to an emergency department. And so I think your question highlights a really important element of screening at borders, which is that simply a fever check at a border is not enough to keep Ebola out of the country. Asking people about their symptoms isn't enough. Even a lab test wouldn't show that someone is Ebola negative. That's why it's so important to have this enhanced surveillance locally, so that when symptoms do develop, we're able to handle cases appropriately.
Thank you.
Dr. Foreman and Brian.
Thank you. I'm just so impressed with the work that the Department of Health is doing. So it's really reassuring to me, even though it's a scary situation. You mentioned the risk to healthcare workers, and I'm sure you know in the news there is a healthcare worker in Spain who apparently did acquire Ebola caring for a patient. So I had a couple questions related to that, and it's interesting how challenging the medical waste problem is. I wondered if there are any solutions to that, and if you've done any additional work with healthcare facilities around protection of healthcare workers, particularly how long the virus persists in fomites, the doffing or removal of gowns, which people aren't always so good at doing appropriately, and perhaps that's the source of the problem. Because I appreciate the sort of fear that might grow amongst healthcare workers that could then be a problem for responding to a case.
Yes, it's a challenging problem because the level of infection control that has to be done is not greater than for other diseases, but you have to be very meticulous about it. And your point about putting on and taking off the PPE appropriately is a really important one. So what we've been encouraging our healthcare facilities to do is to have a plan for what PPE they plan to use, ensure that it's stocked in all the places where they might encounter a patient, so in the emergency department, or on whatever floor they plan to have the person isolated, make sure that all the staff have just-in-time training for it. And we've also been encouraging them to use a buddy system. This is something that's been successful for some of the organizations that are actually working in the field in West Africa, is to have someone observe the person putting on, but more importantly, taking off the PPE when they exit the person's room. So we're encouraging facilities to do that. I mean, it's a challenge for staffing, not only because people may have anxiety about working with those patients, but also because now we're talking about a lot of extra people who would be needed to make sure that it's done at the highest level of precaution. So, we can't mandate that hospitals do that, but that's sort of among the guidance that we're giving them to ensure that they're ready to take care of a patient if they have one. And then your question about the medical waste, I want to address that one also, as it's a really important one. So we learned last week that this became a humongous issue for the city of Dallas, as they were trying to handle not only the medical waste where the patient was hospitalized, but also the environmental control of the house where the patient was when he was becoming ill. So the way that has worked out is that Dallas, the medical waste contractor, who is the one who has to haul the waste away, has gotten a waiver from the U.S. Department of Transportation so that they're not subject to this Category A requirements. However, that only applies for that certain situation, and so my understanding is that they would have to, if we were to have a patient, they would have to apply for that exemption here as well. So we're looking into ways that might be able to be achieved preemptively, but I don't have an answer for it. There's no solution in place at this moment. But I've been told that it would happen quickly if we needed it to happen.
Could I just follow up and ask, do you know how long Ebola persists in fomites in the environment?
I'll let us.
So there are a few scientific studies that have looked at this. There is some published literature that shows that it can still be detected in an active form on the surface for up to a few hours before it dries out and is inactivated. That's a suggestive piece of information. What it actually means in a clinical and epidemiologic setting is a much more challenging question. So really our best data on how people are getting infected is coming out of 3 countries in West Africa right now. Certainly the bulk of the efforts there are focused on limiting spread, not on studying the persistence of virus on surfaces, as much as we might like to know some of the science here. But my understanding is that from all the cases that have been studied in West Africa during this current outbreak, they all do have a clear epidemiologic link with another case. And so while there are concerns that persistence in fomites, so persistence on surfaces in small amounts of dirt, could represent the risk, we think that the real risks are coming in direct contact with a patient when they're severely ill, coming in contact with blood, stool, or vomit, even if it's soaking a sheet for several hours afterwards, but the small amounts that we can't see are probably not going to be a large source of the action.
So, thank you very much for your presentation, and thank you both for your questions, my colleagues, because it's cleared up some things on my mind. I do want to say, though, that New York City has such a great history of rising to the occasion. I think, I have long believed that the New York City Health Department is really the finest in the country, and I can see that demonstrated here today. Last week I had the opportunity to hear Dr. Frieden present on a number of issues. He talked in a little bit more detail about what is happening, what the CDC is doing in airports around the country. I know you're not responsible for it. It plagues me a little bit to think about a sort of a large sea of patients coming in to the airport on a regular basis and how one sort of separates out the people of interest from that large group. Maybe you could say just a word or two about what you understand of the process, because so much of that really is sort of the primary place where we can be protected. Is that possible or not?
So your question is, how do they
Well,
find the people who are sick
I'm just
among
curious,
all
so
those queues?
that's one question. If you could describe like the Cliff Notes version of, you know, what they're doing.
Right, I mean, there are different ways that a person who's sick could be brought to the attention of the CDC quarantine staff, at least, you know, how it's currently working, and I can't speak to what CDC's plans are to change what they're doing in light of the current events. But in terms of how it normally works for any communicable disease, if a patient becomes ill while they're en route, the planes, the airline staff notifies their airline, you know, central at the Port Authority. The Port Authority, I think I'm getting this right, the Port Authority contacts the CDC quarantine station. Depending on the situation, Port Authority EMS and the quarantine station could respond to the plane. The quarantine station staff can board the plane and assess the situation before people are, can get off the plane, so yeah.
So, just one or two other questions. So, you're working, I'm assuming with Greater New York and all the usual suspects who come together. I was actually at Bellevue in the early 90s when Dr. Friedman and others were quarantining TB patients. But I guess my main, well, two things. One, are you thinking at all about doing drills in some way in hospitals and other health centers?
So we are thinking about that. Several hospitals are doing that on their own. One that is a common one is a mystery patient that presents to the ER with the,
Yes.
you know, per group track. So some hospitals are doing that themselves. And New York State has recently encouraged hospitals to take that on also. So, you know, we haven't been going out to do those drills with hospitals, but we're definitely supportive of that. We're also planning an exercise that wouldn't be a drill, it would be more of a facilitated discussion with a lot of the, you know, key agencies that would be involved in managing a high-risk case. And we're actively planning that facilitated discussion to happen, you know, in the next few weeks to maybe 3 to 4 weeks.
That's great. As a hospital CEO, I worry far more about the community-based providers than I do about what goes on in our emergency room. And I think there's a whole far-flung network of health and medical and health and social service organizations that may or may not have a protocol in place.
So one of the first documents that we got out actually was the guidance for outpatient facilities. Who do they need to identify? What do they need to do with them? Put them in their own room and call the health department. That was basically the guidance that was going out to outpatient clinics. It went out, I think, even at the same time or as soon as our first time came out, that was going out to outpatient facilities. They are a little bit harder to reach because there are so many of them compared with hospitals.
Yes.
So we do have a number of ways that we reach out to the primary care community. We work with an organization called the Primary Care Emergency Preparedness Network that mainly reaches federally qualified community health centers, other like similar larger community health centers. And they do reach some smaller health centers now. They're trying to expand their reach into that a little bit. The Health Department's Primary Care Information Project has contact information for a wider array of different types of primary care. So we put out all these same messages through all of these means, basically. And we're also now reaching out specifically to urgent care centers, although many of them started getting our HANs when the measles outbreak happened this year, so many of them already are getting our HANs, but we're going to do a separate outreach to urgent care centers starting this week.
Lastly, one comment. Some of the CBOs and ambulatory programs around the city are coming together to do these Medicaid waiver or DSRIP projects, and there probably are there's 250 at least in Brooklyn, I know that, not counting hospitals, so you might consider trying to just get those sort of an email listing of all of them, or maybe you've already done that yourself.
We haven't done it, we have thought about it, and it's a great idea. I think there are a lot of opportunities for emergency preparedness with DSRIP and with the general changes in the healthcare system, absolutely.
Great.
I would also just add to that Ebola sort of preferentially strikes healthcare workers. It shows up in patients who are sick. They go to hospitals and clinics, and they infect healthcare workers. And healthcare workers need to be able to protect themselves. And so a lot of outpatient clinics don't necessarily have the gowns and gloves and masks to throw on every time they see someone with a fever. And for those settings, they really shouldn't be. If they hear about a patient that has symptoms, they shouldn't say, "Great, we'll book you at 2:30." They should say, "Go somewhere where you can be seen by workers that can keep themselves safe."
Yeah.
So an important part of our message is to make sure that that is getting across, and that if clinics are not able to build capacity to protect their workers, that they're just referring patients appropriately.
And you've given those providers exquisite information on where to call at Bellevue and how to make that happen.
No, if an outpatient clinic has a patient who has a fever and has traveled to West Africa, they immediately notify the health department, and we will arrange transport for that.
And you do it, okay. Thank you.
Thank you for your very thorough presentation. I had the opportunity of being on the conference call at the beginning of August, and that was very informative for all of the clinicians in our area. But I had one question about the non-clinical hospital staff, which invariably, that's the first person the patient's going to see. They're going to register the patient and say, "Oh, have a seat in the waiting area." Is there any specific training or education for that staff?
Right, I mean, we are encouraging hospitals to have this stop triage poster that I showed on one of the slides prominently posted at the entrances and in the triage areas. It asks patients to self-identify, but we also want hospitals to have it part of their protocol that their initial frontline, whether it's security, whether it's an administrative person or a triage nurse, that all of those people are asking people, especially if they look sick, have you traveled, and then notify the appropriate person, isolate them, and then call the health department. That's what we're encouraging.
And I would just add that that's something we've been working on with hospitals, not just for months, but for upwards
For
of,
many
say,
other,
a
have
decade.
a collection.
Yes.
Yeah.
Are there further questions from the board? Then I want to thank you for the
It's great,
information.
really good, great.
Thank you.
We have one more short presentation regarding Article 165 of the New York City Health Code, pretending to be on the staff.
So, in my old age, I know where two one to read, one to see. I'm gonna put on the reading ones.
And
It'll have to be very emotive. If you want me to say.
introduce yourself.
Yes, exactly.
Hi, I am Chris Boyd. I'm the Assistant Commissioner for Environmental Sciences and Engineering.
Yes.
And I'm coming back to give the board an update on some activities that we've taken since we passed some changes to Article 165. You may recall that we had a petition to the board to amend the code to specifically address risks associated with dangerous underwater breathing behaviors, which we defined as doves. And one of the things that we did at that point was we changed the code to allow us to require bathing establishments to update their pool safety plans upon request and when there's a significant change in operation. And to consider developing a pictorial sign that would communicate to younger patrons the risks with dangerous underwater breathing behaviors. And so this is an update for both those things. And there's a specific request to kind of go through what's in a pool safety plan, how does it work, and so we're going to quickly do that. I know it's been a long session. So first, I'm going to go through some of the changes to the safety plan. It's a written document that's submitted to the department. It must outline the policies and procedures to be followed by the facility personnel, both for routine activity and response to an emergency. The plan itself is guided by a couple sort of foundational documents. It's the New York City Health Code, it's the State Sanitary Code, the New York State Department of Health has a full safety plan that provides some guidance, and we also have some safety plans around spray parks, which are can be a source of broad outbreaks. So what we've done is developed a few new tools in the plan to assist bathing establishments to have consistent plans and develop a consistent approach to safety, both emergency response and to disinfection. And we're in the process of establishing a schedule that all facilities in the city of Newark would update their safety plans. We have about 750 facilities in the city. So some of the things that have been updated, we've included in the plan links to safety information, both at CDC and other stakeholder organizations. The facility must present a protocol for lifeguard positioning, rotation, breaks, and distractions. This is an extremely important thing in terms of bather supervision. You need to rotate out those lifeguards so their attention can be focused on safety. You don't have them take out the garbage. You don't have them do other things. Their job is to supervise patrons and respond to an emergency. Also, we included some specifics about how to deal with outside groups that come to a pool. So if somebody's doing, let's say, physical therapy in a bathing establishment, what's the additional supervision that's needed for that? You've got, let's say, a group of physically disabled people who are doing activity in the pool that needs a different level of supervision versus, people who are doing that. And then also to make clear that when regulated child care facilities come to a pool, that all the bathing, all the supervision that's required is there, and the protocols that are supposed to be followed are also in place. There's a buddy system that has to be in place for a child care facility and that sort of stuff. So we've got some new tools in the plan. We've got a standard checklist for routine safety inspections and equipment and maintenance that needs to be there. That provides a document for us to inspect to verify that those routine things are in place. And a lot more details in the plan about how do you deal with a contamination event, stool, vomit, that kind of thing. And then moving on to Dubs, so we wanted to move forward with a pictorial sign only if we felt that the sign itself would be impactful and helpful. So we took some time to think through what would a pictorial representation of this risk be. Would young people understand it? Would they be able to interpret it? Would they respond to it? So in order to do that, we worked with what's called a wayfinding firm that does public-facing signage. They developed a series of templates for us to look at and evaluate. In collaboration with the YMCA, we reached out to about 250 young swimmers in a focus group setting, presented them variations of the sign, got feedback from them, validated the language on the sign one more time. So we went out to public pools to do that, and felt that we developed a sign that would be communicative and impactful, and would be in addition to the required language, which is on all of the entry rule signs, which is prolonged or repetitive breath holding can be deadly, no intentional hyperventilation underwater competitive breath holding yes, a 12-year-old will not understand what all that means. But we believe a 12-year-old will be able to understand this,
Yes.
which is no breath holding contests, taking deep breaths one after the other before swimming underwater can be deadly. So from our case studies of these incidents in New York State, if I'm remembering correctly, we had 16 identified cases. We did a case review, came up with what we thought was a good case definition. We're actually presenting that to the CDC for an MMWR for their consideration. That young people is our largest group at risk. It's young boys primarily, often in groups, participating in breath holding games and breath holding contests. Deaths are associated with adults who are behaving in ways that they shouldn't. But it's a very different kind of scenario where somebody's doing intentional hyperventilation, swimming laps, and then collapsing straight to death versus a group of kids who are doing this activity. So we got good feedback from the young people. They improved the presentation, and they told us that this would work. So there you
For
go.
you. Great,
Thank you.
great.
Yes, and any comments other than accolades from the board?
Great.
So you have, thank you very much. All right, I then declare this session of the board open. And the time is something like 11:40. It is 11. Great, okay, yeah, it's,